Hypothetic abduction is essentially what you do in your clinic. Um, in general, hypothetic abduction incorporates both single and multiple listings of diagnoses. When there's multiple listing, it's called differential diagnosis. When it's a single listing, it tends to be called hypothetic abduction. We'll use the same convention here. When I'm talking about hypothetic abduction, generally I will mean a single hypothesis that's being tested. If I'm talking about differential diagnosis, it means there's a list of them. But the process is much the same between the two. And we'll cover differential diagnosis after this, but this will give you the principles of it. So hypothetic abduction is best fit. It's what you do in your clinic nearly all of the time, this differential diagnosis. But abductive reasoning is what you tend to use in your clinic. You ask the patients about their signs and symptoms, and then you try to fit those signs and symptoms into the best explanation for a diagnosis that you have in your head. Now, this could be better organised or less well organised, depending on you and how much you know the subject. We're going to try and get around that by giving you illness scripts, focused illness scripts, essential illness scripts, to help you organise things better than maybe you have been doing. But essentially, that's what you do. The patient starts to tell you their signs and symptoms. You immediately start thinking about a diagnosis. You don't wait. You don't ask 10 signs and symptoms. Do different tests, and then at the end of it say, I know what this is that. You don't do that. As soon as they open their mouth, you're thinking, this is tennis elbow, this is a medial ligament problem, this is a meniscus, this is a mechanical back pain problem. You immediately start pattern recognizing, because that's what humans do anyway in general life. This is what you do in your clinic. When you hone this to a skill, pattern recognition becomes an extremely reliable tool. But nonetheless, you use it immediately. So my recommendation is you take the first one or two symptoms, no more than that, and then basically you generate a hypothesis and make it conscious for a while. It will become unconscious, or at least subconscious, but make it conscious for a while and then work with it. So you have your hypothesis, you have an illness script that describes that condition, and then you see if the patient's signs and symptoms fit that illness script. Now, the illness script can be better or worse. It can be a focused illness script where you can incorporate different things if you need to, or it could be the essential illness script that will give you the minimum requirements to identify the condition. My suggestion is you use the essential illness script, and once you've done that, then fill it out with outlying questions and extra stuff to make it richer and fuller and more certain that you are correct. But use the illness scripts either because they're in your head or you've learned them from a book. So this is hypothetic abduction. The only difference between the two is that hypothetic abduction tends to be iterative. That is, you repeat the process when the first hypothesis doesn't work, whereas differential diagnosis, you've got a list of them, you go through the list and see which one of those best fits. The reason you might use hypothetic abduction rather than DDX is that you've got a simple condition, something like lateral elbow pain. You know perfectly well that in your practice that this is 90% of the time going to be caused by a tendinosis, a tennis elbow. Whereas if somebody comes in with low back pain, there are multiple things that can cause this, all equally plausible and equally likely. So this one you make a list, and preferably, my preference would be to do this exclusionary differential diagnosis to eliminate the non-suitable candidates and concentrate on the ones that require positive value. Anyway, that is hypothetic abduction. Let's look at it in a little more detail. This isn't definitive, obviously. You're not going to be able to make a diagnosis based on one or two symptoms in a test. But it will also get you started on the hypothesis. And given that the hypothesis is your basis for testing, this is an absolutely necessary step. The sooner you do this consciously, the better. So how do you select this? Well, there's a number of different ways, especially if you're just using a single symptom. So let's say they say the pain is on the lateral elbow again. I'm sorry to keep using this, but it is going to be consistent all the way through this, and it's something we will understand. So lateral elbow pain. You look at the surface anatomy and what underlies the skin, and there is your local problems right there. So all you need is your anatomy to start with. So we've got the skin, subcutaneous tissue, fat, and so on. I have no idea about any of these, so these don't come into the equation. The next one down, though, will be the tendon and the tenomuscular junction around the elbow that way. So your first hypothesis is there's a tendinopathy there, or a tenomusculopathy, if you like. So this could be your first hypothesis. Going down a little bit further, we come to basically the epicondyle. The epicondyle, the bone that is the joint and the ligaments. So looking at this, we've got the capsule. You could have torn the capsule, but you need trauma for that. It could be an arthritis. That doesn't necessarily need trauma. That could be a systemic arthritis, or it could be an osteoarthritis that's been microtraumatically injured in areas that's somewhat inflamed. So it could be an arthritic condition. It could be a biomechanical dysfunction of the joint. It could be a degenerative ligament tear, or if there has been trauma, a frank, healthy tissue, a healthy ligament tear. So all of these have to be considered, and this is the way you select, or you can select, your first hypothesis. If you have a few more symptoms, then pattern recognition may kick in. And pattern recognition is a perfectly acceptable way of generating a hypothesis. In fact, it's used very frequently to actually generate a diagnosis. And I'll come back to that later when we start talking a bit more about pattern recognition, but I can't teach that. And you can't learn it. You have to develop it from quality experience. Similarly with intuition. Intuition you can use for hypothesis deduction, for hypothesis generation rather. Some people will use it for diagnosis. Not the best idea in the world, but it could be a starting point for this. It is very important, though, if you get a bad feeling about something, a bad gut feeling about something, you need to act on that. You may not know why you've got that gut feeling, but you need to act on it. But that's not diagnosis, that's management. So pattern recognition is the way to go if you've got enough symptoms there. And then there are the illness scripts. You're either carrying them in your head or they're book learned. You've been taught this at school or from other therapists, or you developed your own illness scripts, but these are basically learned processes. So you've got a number of different ways of generating the hypothesis. Probably the one that you're going to use by far the most is using your anatomy. What lays under the painful area? And for this, you need good anatomy. And if you've sort of sloughed off on this and you're not bothering too much with it, get it again. That and pathology are both important tools that you carry around in your head. This is not something you need to go to a book for, or should need to go to a book for. This should be in your head, ready to use. So this is hypothesis selection, and it's your mandated first step. You cannot not select a hypothesis either with differential diagnosis or with hypothetic abduction. The next step is to test a hypothesis. So to do this, it's not a matter of asking the patient random questions and doing random tests. These have to be focused on the hypothesis. So you need to access the focused illness script or the essential illness script. When I say access, I mean it should be in your head, but if it's not, then you need to look it up. But the questions and tests should come from the focused illness script or the essential illness script, so that you can then make a direct comparison of the patient's symptoms and your idea of the illness script. So if these match up well, then basically you have a provisional diagnosis that's ready for biosideric testing. If they don't match, then you have to generate a new hypothesis, and that means using the information you've already gained when you was testing the first hypothesis or subsequent ones with the information you're gaining from the patient. So it's an ongoing process. It's sort of a stacked differential diagnosis, but it's stacked rather than listed at one go. Okay, based on what you find when you compare the patient's signs and symptoms to the focus illness script of the hypothesis you're testing, you can do one of a number of things. First, you can retain the hypothesis. That is, it's proven to the point where you're happy with it, that it's most probably true. That is, the hypothesis can now be turned into a provisional diagnosis that you can then mitigate for bias and error, and then if that pans out, use it to generate a treatment plan and a prognosis. You may have to modify the hypothesis. It's possible that your hypothesis was it was a tendinopathy, and the course of taking information from the patient, both physical and testing, it actually refines it down from being a tendinopathy to a tendinosis or a tendinitis. You may also think that it's a medial collateral ligament tear in the knee, and there may be a medial collateral ligament tear there, but it's also coupled with a meniscus tear. So you may have to add a second diagnosis onto that hypothesis. So you can modify the hypothesis depending on what you found. You can completely throw out the hypothesis. It's just plain wrong. So when you do this, you have to generate a new hypothesis, and this is done on information you've gained from making the hypothesis. And this discarding of hypotheses that haven't panned out can be repeated and repeated and repeated. And as I say, the more often you repeat this, the less bias and error will creep into your examination, and the more probable the end result will be to be true. So we're going to look now at a diagram that will sum this up very simply, and we'll go from there. Okay, so a very simple diagram, essentially looking at what we've just talked about. So we choose the first usable symptom or initial symptoms to generate the hypothesis. As I say, this is mostly where the pain is. So we generate a hypothesis and we access the focus illness script, and we compare the patient's signs and symptoms with that focus illness script. If it fits, we have our provisional diagnosis that we can then move on to bias and error correction. If there's a misfit, we generate H2 on the new information gained from asking the patient about their signs and symptoms, and then take the whole thing back into the same iterative cycle. So we just keep going round and round until we find a hypothesis that fits. Now, this seems a little cumbersome, but it isn't. If you only use hypothetic abduction for reasonably simple diagnoses where there aren't too many plausible candidates for the diagnosis, then you won't go over and over and over this again and again. You'll probably get it on the first or second go round. If you're looking at a more complex condition, then move to differential diagnosis and then use exclusionary differential diagnosis to reduce the candidates down to a manageable number, and then go back into positive vetting with hypothetic abduction. This then is hypothetic abduction, as an introduction at least. It is an iterative process, and it can be used for simple or complex diagnoses. When it's simple, you can use hypothetic abduction as a single case where you just go over the cycle over and over again until you reach the best fit. If it's more complex, then what I would strongly suggest you do is make a list of the differentials and then reduce them by exclusionary differential diagnosis. Use very sensitive tests, questions to eliminate the diagnosis you know perfectly well are not going to fit, and then you're left with one or two that you can then positively vet with hypothetic abduction. So that's all it is. It's what you do in the clinic. But I want you to start taking notice of how and why you're doing it. If to understand the process, it needs to be a bit more conscious than maybe you're doing it. You will return to the less conscious version of it, but right now I want you to understand that you can only understand it by inspecting it. being critical of it and working with it. Okay, the next video we'll look at differential diagnosis in a little bit more detail on that. For the moment, we'll be done with hypothetic abduction. Bye.